Hey guys, I'm Jackie Wooden and I'm going to do a video response to Karen Hushka's Goldilocks. So I do agree with your assessment of history and contributing factors. Goldilocks is presenting with worsening anxiety and ADHD symptoms. A more biopsychosocial perspective strengthens the assessment though. So biologically, she has a strong genetic predisposition with maternal anxiety depression, along with that paternal ADHD and substance use disorder. This significantly increases her psychiatric risk, according to the DSM-5. Psychologically, her symptoms escalated after her mother's motor vehicle accident, which suggests a trauma-related trigger contributing to her anxiety severity. From a sociocultural standpoint, family disruption, limited paternal involvement, and possible instability in the home environment may exacerbate emotional dysregulation. Additionally, her excessive screen time, reported at 6 hours daily, is clinically relevant, as increased screen time exposure is associated with worsened anxiety, impulsivity, and behavioral dysregulation in children. And that's from Twenge and Campbell 2018. Her aggressive behaviors also indicate impaired emotional regulation that warrants further intervention. So for your diagnoses, I do agree that generalized anxiety disorder is present, as she meets the DSM-5 criteria, including excessive worry, irritability, and impaired functioning for over 6 months. I would like to challenge, though, the relative weighting of separation anxiety disorder as one of your differentials. Her symptoms, especially distress related to separation after the trauma of her mother's car accident, strongly support separation anxiety and may even be more prominent than the generalized anxiety disorder. Research shows that trauma can precipitate or worsen separation anxiety in children, and that comes from Silov et al. 2015. Additionally, although PTSD was ruled out, I would recommend continued monitoring for this, as children may present with delayed trauma responses, and that's also from Silov et al. 2015. For your treatment plan, so I do agree with initiating cognitive behavioral therapy as first-line treatment. Evidence consistently shows that cognitive behavioral therapy, particularly when families involved, significantly reduces pediatric anxiety symptoms, and that is from Walter et al. 2020. Pharmacologically, so switching from fluoxetine to sertraline is totally appropriate. Sertraline has a strong evidence for pediatric anxiety and is often better tolerated in patients. Fluoxetine can be activating, which can cause increased irritability in an already anxious and irritable child. So my preceptor says that we would prescribe Prozac only if a child is only depressed. If that child is presenting with anxiety and trouble sleeping, then we would use escitalopram. But for a child such as Goldilocks, who's anxious and irritable, we would prescribe sertraline. So I do agree with that choice. I would suggest a more cautious reassessment of her ADHD treatment. I do realize that the atomoxetine is appropriate, especially given that she had some stimulant-induced tics, but her persistent impulsivity and aggression suggests suboptimal control, as atomoxetine is more useful for inattention. The dose optimization is reasonable. However, switching to guanfacine may actually help target the impulsivity and aggression, and that's from the Shanghai Archives of Psychiatry 2025. Another option is to keep the patient on the atomoxetine and add clonidine at night to help reduce irritability and aggression. That's from Turk et al. 2023. Turk et al. So for patient and family education, I'd like to expand the education plan to include reducing this patient's screen time, as the excessive screen time worsens the emotional and behavioral symptoms. Also, parent management training to address aggression and oppositional behaviors, and psychoeducation on anxiety triggers and coping strategies. Family involvement is critical, as parent-guided interventions significantly improve outcomes in pediatric anxiety disorders. That's from Walter et al. 2020. So for question number 1, you asked about pharmacogenetic testing. Key et al. Report that pharmacogenetics has potential for optimizing use of psychotropics. Potential being the key word here. I do believe that genetic testing can play an important role in guiding medication selection, especially in children when parents don't want to switch from this med to that repeatedly. Trialing psychiatric medications on children can be stressful for both the child and the parent and the PMHNP. Therefore, genetic testing can be helpful. And I use the phrase guiding medication selection. So this is because you can't and should not rely on genetic testing alone to choose your medications for you. One example of this is I had a patient, this is off topic, but I did have a patient last week. It was an adult patient. However, she was being seen in a follow-up. She had PMDD. She was placed on Prozac, and she did genetic testing. So when we saw her, we looked at her genetic testing. Her gene site was saying Prozac was probably not a good choice for her. Well, the patient said Prozac was great. So she was on a very low dose, so it worked out. But that just goes to show you that the genetic testing cannot just rule out a medication just because it says that the patient it may not be the best med for the patient. So in Goldilocks' case, genetic testing could be clinically reasonable due to her adverse response to fluoxetine. However, I think that there's another reason that she had trouble with fluoxetine, but we'll get to that. It could help identify whether altered metabolism contributes to side effects and guide dosing or medication selection moving forward. However, the successful response of her mother to sertraline should not be overinterpreted as predictive, as familial response does not reliably correlate with pharmacogenomic profiles or individual treatment outcomes. So fluoxetine and sertraline are both SSRIs, metabolized in part by the CYP2D6 and CYP-C19 pathways. Variability in these genes can result in poor, intermediate, or ultra-rapid metabolism, which may lead to either increased side effects due to higher plasma concentrations or reduced efficacy due to subtherapeutic levels. In this patient's case, the lack of efficacy with fluoxetine and the emergence of adverse effects at higher doses raises the possibility of atypical drug metabolism, such as poor metabolizer status, which the genetic testing could help clarify. And again, I'll get back to that. We'll circle back to that in a second. But other reasons to use genetic testing are, like we saw in Brittany's case study, patients that may carry the MTHFR gene variant. So Kahn et al. Report that the MTHFR is an enzyme involved in the metabolism of folate. And they go on to say that many psychiatric conditions are related to this MTHFR gene variant, including ADHD, autism, anorexia, anxiety, obsessive compulsive disorder, depression, and mood disorders. So yes, it can be helpful. Additional medications. So question 2 was what other medications could be considered. So if anxiety and emotional dysregulation persist, as previously mentioned, I would switch from atomoxetine to guanfacine because it sounds like this patient's main problem is not inattention, it's the impulsivity and the aggression of the ADHD. Guanfacine can help reduce those. So I would do that. I would switch from atomoxetine to guanfacine. Or, and I mentioned this earlier, I would add clonidine. Clonidine at night is going to help with irritability and aggression, and then improve daytime focus next day. Another thing we could do is short-term adjunctive use of hydroxyzine, and this can help reduce anxiety symptoms, and that's from Patel et al. 2018. We want to optimize the SSRI dosing before we add any agents, as polypharmacy should be approached cautiously, prioritizing psychotherapy and careful titration of current medications. So in conclusion, I do agree with most of the diagnostic and treatment approach, but I do recommend a greater emphasis on possible separation anxiety, also adding trauma-informed care, behavioral interventions, and then family involvement, and then the pharmacogenetic testing if the patient's symptoms do not improve. And that is all. I will provide a reference list and ignore my previous posts because I didn't follow directions, but that's it. Hope you enjoyed it.